Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today here on Unit 18, we're talking about therapy of infectious and parasitic diseases. Specifically, Chapter 80, Drug Therapy of Sexually Transmitted Diseases, or STDs. So, sexually transmitted diseases, or STDs, also known as sexually transmitted infections, or STIs, are infectious diseases transmitted primarily through the sexual contact. STDs or STIs are very common in the United States and constitute a major public health problem. In 2014, the CDC reported a sharp increase in the number of reported STIs for the first time since 2006. For three STTs in particular, the increase from 2013 to 2014 alone was dramatic, and that is with syphilis rates that increased by 15.1%. Congenital syphilis rates increased 27.5%. Gonorrhea rates increased 5.1%, and chlamydia rates increased 2.8%. Bear in mind that those are known reported STDs. Because most STDs go unreported, the actual incidence is much higher, estimated at 20 million new infections annually, more than 50% of which occur in people younger than the age of 25. According to the CDC, Americans now have a 25% lifetime risk for contracting an STD. Our objective in this chapter is to describe the principal STDs and provide an overview of their treatment. The basic pharmacology of these drugs are discussed in other chapters. HIV infection is covered separately in chapter 79. So here is an outstanding spot to hit pause so you can see the drug therapy recommendation for different STDs. And this is quite a long list, so I'll make sure it makes sense to hit pause in several different spots. So, in 2015, the CDC updated its sexually transmitted disease treatment guidelines. The treatment recommendations presented in this chapter reflect those guidelines. So, let's start with the first STD, chlamydia trachomatis infection. Its characteristics. Chlamydia trachomatis is the most frequently reported bacterial STD. The various strains of chlamydia can cause genital tract infections, proctitis, conjunctivitis, and lymphogranuloma venereum, as well as ophthalmia and pneumonia in infants. Infection is frequently asymptomatic in women and may also be asymptomatic in men. In women, untreated infection can cause pelvic inflammatory disease, ectopic pregnancies, and infertility. The CDC estimates that chlamydial infections cause sterility in up to 50,000 women each year, primarily from a fallopian tube scar. Because infection is asymptomatic in women, and because sequelae can be serious, the CDC now recommends annual screening for all sexually active women 25 years or younger. Screening is also recommended for women older than 25 years who have a new sexual partner, multiple partners, or a partner with a history of an STD. So, its treatment. Adults and adolescents. For the uncomplicated urethral, cervical, or rectal infection in adults or adolescents, treatment with either azithromycin or doxycycline is recommended. Patients who are unable to take these medications may take erythromycin, levofloxacin, or ofloxacin. Table 80.1 provides a detailed summary of specific dosages of drugs used to treat chlamydia and other STDs. Infection and pregnancy. Azithromycin is preferred treatment for C. trichomatis infections, although doxycycline and other tetracyclines are active against the C. trachomatis. These drugs are contraindicated because they can damage fetal teeth and bones. If the patient cannot take azithromycin, the approved alternative is amoxicillin, erythromycin base, and erythromycin ethylsuccinate. In infants, about half the infants born to women with cervical C. trichomatis acquire the infection during delivery, putting them at risk for pneumonia and conjunctivitis. Pneumonia is generally not severe and lasts about 6 weeks. Conjunctivitis does not result in blindness and spontaneously resolves in 6 months. The preferred treatment for both infections is oral erythromycin base or erythromycin ethylsuccinate. Azithromycin suspension may be given as an alternative, although topical erythromycin, tetracycline, and silver nitrate may be given to prevent conjunctivitis. These drugs are not completely effective, and they have no effect on pneumonia. The pre-adolescent children. Although infection in pre-adolescent children can result from perinatal transmission, sexual abuse is the more likely cause, especially in children older than 2 years. Because of the legal implications, diagnosis must be definitive. Treatment depends on the age and weight of the child. For children who weigh less than 45 kilograms, the preferred treatment is oral erythromycin base or erythromycin ethylsuccinate. For children who weigh 45 kilograms or more, but are younger than 8 years, the preferred treatment is azithromycin. For children at least 8 years old, the preferred treatments are azithromycin or doxycycline. Lymphogranuloma venereum (LGV) is caused by a unique strain of C. trichomatis. Transmission is strictly by sexual contact. LGV is most common in tropical countries, but does not occur in the US, especially in the South. Infection begins as a small erosion or papule in the genital region. From this site, the organism migrates to regional lymph nodes, causing swelling, tenderness, and blockade of lymphatic flow. Tremendous enlargement of the genitalia may result. The enlarged nodes, called buboes, may break open and drain. The treatment of choice for genital inguinal and anorectal LGV is doxycycline. Erythromycin base serves as an alternative for those who cannot take a tetracycline antibiotic. Which brings us now to the gonococcal infections. Their characteristics. Gonorrhea is caused by Neisseria gonorrhoeae, a gram-negative diplococcus, often referred to as the gonococcus. Gonorrhea is the second only to chlamydia as our most common STD, or STI. Gonorrhea is transmitted almost exclusively by sexual contact. The intensity of symptoms differs between men and women. In men, the main symptoms are a burning sensation during urination and a pus-like discharge from the penis. In contrast, gonorrhea in women is often asymptomatic or may present as mild cervicitis. However, serious infection of female reproductive structures, including the vagina, urethra, cervix, ovaries, and fallopian tubes, may occur, ultimately resulting in sterility. Among people who engage in oral sex, the mouth and throat can become infected, causing sore throat and tonsillitis. Among people who engage in receptive anal sex, the rectum can become infected, causing a purulent discharge and a constant urge to move the bowels. Bacteremia can develop in males and females, causing cutaneous lesions, arthritis, and rarely, meningitis and endocarditis. So, its treatment. Owing to antibiotic resistance, treatment of gonorrhea has changed over the years, and undoubtedly will continue to evolve. In the 1930s, virtually all strains of gonococcus were sensitive to sulfonamides. However, within a decade, sulfonamide resistance had become common. Fortunately, by the time penicillin had become available, the drug was active against all gonococcal strains. Since 1976, organisms resistant to penicillin, however, started to emerge. More recently, resistance to fluoroquinolones has become common. So as a result, in 2007, the CDC recommended against fluoroquinolones for gonorrhea, leaving cephalosporins as the preferred treatment. This recommendation was changed yet again in 2012, also triggered by antimicrobial resistance, this time to oral cephalosporins. Urethral, cervical, and rectal infections. Because of increasing resistance to the cephalosporins, preferred treatment now consists of a combination of two drugs, ceftriaxone intramuscular plus azithromycin. If the patient refuses IM therapy, oral cef- cefixamine can be substituted for IM ceftriaxone. However, the CDC recommends not routinely substituting the drug because resistance to cefixamine has been documented and is anticipated to continue to increase. If a patient is allergic to azithromycin, a 7-day course of doxycycline may be substituted. For patients with a cephalosporin allergy, the options are not as clear. Although prescribing double the azithromycin dose as a monotherapy will help cure gonorrhea in most cases, the CDC does not recommend this treatment because treatment failures and rapid development of resistance. Although acknowledging a lack of data for recommendation, the CDC is suggesting substituting gemifloxacin for the cephalosporin component, despite having recommended against using quinolones to treat gonorrhea. Spectinomycin, an aminoglycoside, has also been suggested. However, it is not currently available in the US. For additional information on this dilemma, you can take a look at the CDC's website. Pharyngeal infections. Gonococcal infections of the pharynx is more difficult to treat than an infection of the urethra, cervix, or rectum. Therefore, parenteral therapy is recommended for all patients. The preferred treatment is ceftriaxone combined with azithromycin. Azithromycin is preferred over doxycycline because patients are more likely to adhere to a single-dose regimen of azithromycin than a full-week regimen of doxycycline taken twice a day. Conjunctivitis. Gonococcal conjunctivitis can be reliably eradicated with ceftriaxone plus azithromycin. Treatment also includes washing the infected eye with saline solution once. Disseminated gonococcal infections, also known as DGIs, occur secondary to gonococcal bacteremia. Symptoms include petechial or pustular skin lesions, arthritis, arthralgia, and tenosynovitis. Endocarditis and meningitis occur rarely. Strains of N.Gonorrhoeae that cause DGI are uncommon in the United States. In the absence of endocarditis or meningitis, treatment should consist of an IM or IV ceftriaxone plus azithromycin. For patients who have endocarditis or meningitis, the preferred treatment is IV ceftriaxone plus azithromycin. Neonatal infections. Neonatal gonococcal infections is acquired through contact with infected cervical exudates during delivery. Infection can be limited to the eyes or it may be disseminated. Gonococcal neonatal ophthalmia is a serious infection. The initial symptom is conjunctivitis. Over time, other structures of the eye become involved. Blindness can result, and the recommended therapy is a single dose of ceftriaxone, given by either IM or IV injection. To protect against neonatal ophthalmia, a topical antibiotic should be instilled into both eyes immediately postpartum, as required by law in most states. According to the 2015 CDC guideline, the only approved topical agent is a 0.5% erythromycin ophthalmic ointment. If this antimicrobial is not available, parenteral therapy with ceftriaxone is to be used instead. In neonates, DGI is rare. Possible manifestations, however, include sepsis, arthritis, meningitis, and scalp abscesses. There are two recommended treatments, ceftriaxone and cefotaximine. If meningitis is present, dosing is prolonged from 7 days to 10 to 14 days. Which brings us to the pre-adolescent children. Again, among the pre-adolescent children, the most common cause of a gonococcal infection is sexual abuse. Vaginal, anorectal, and pharyngeal infections are most common. Because of legal implications, diagnosis must be definitive. Growing a specimen in culture is the preferred technique. Treatment depends on the type of infection and the weight of the child. For children who have localized infections, such as vulvovaginitis, cervicitis, urethritis, pharyngitis, and proctitis, and who weigh about 45 kilograms or less, the preferred treatment is a single dose of IM or IV ceftriaxone. For children with localized infection who weigh more than 45 kilograms, treatment is the same as for adults. For children of any weight who have a systemic infection, the preferred treatment is IM or IV ceftriaxone, once daily for 7 days. Specific dosing is again provided in Table 80.1. Which now brings us to the non-gonococcal urethritis. Non-gonococcal urethritis, or NGU, is defined as urethritis caused by any organism other than N.Gonorrhoeae, the gonococcus. The most common infectious agent is C. trichomatis. The other likely agents are Ureaplasma urolyticum, Trichomonas vaginalis, and Mycoplasma genitalium. NGU is diagnosed by the presence of polymorphonuclear leukocytes and a negative culture for N-gonorrhea. The infection is especially prevalent among sexually active adolescent girls. The recommended treatment is either azithromycin or doxycycline. Alternative regimens are erythromycin base, erythromycin ethylsuccinate, levofloxacin, or ofloxacin. For persistent or recurrent NGO, one of two drugs, flagyl or tinidazole, is recommended if T. vaginalis transmission is a suspected cause. Azithromycin should be added to the regimen if it had not been used during initial therapy. If the infection still fails to respond, the cause may be M. genitalium. Unfortunately, we have no easy test for this bacterium, and therefore definitive diagnosis may not be possible. Nonetheless, when M. genitalium is suspected, a trial with moxifloxacin may be warranted. PID, also known as pelvic inflammatory disease, is a syndrome that includes endometritis, pelvic peritonitis, tubo-ovarian abscesses, and inflammation of the fallopian tubes. Infertility can result. Prominent symptoms are abdominal pain, vaginal discharge, and fever. Most frequently, PID is caused by N-gonorrhea, C. trichomatis, or both. However, Mycoplasma hominis, as well as assorted anaerobic and facultative bacteria, may also be present. In recent years, in the US, has experienced an almost 40% decrease in PID, despite the increase in diseases that cause this condition. This may be attributable to the intensified patient education efforts, increased and improved screening practices, or improved adherence to single-dose treatment. Because multiple organisms are likely to be involved, drug therapy must provide broad coverage. Because no single drug can do this, combination therapy is required. For the hospitalized patient, treatment can be initiated with either cefoxitin or cefotetin combined with doxycycline. After symptoms resolve, IV therapy can be discontinued, but must be followed by an oral doxycycline to complete a 14-day course of treatment. An alternative recommended regimen consists of IV clindamycin plus an IV or IM gentamicin. In the outpatient setting, it can be treated with either ceftriaxone or cefoxitin. Treatment again also needs to include doxycycline, with or without flagyl. Because PID can be difficult to treat and because the consequences of failure can be severe, many experts recommend that all patients receive IV antibiotics in the hospital. Acute epididymitis. Epididymitis may be acquired by sexual contact or non-sexually. Sexually acquired epididymitis is usually caused by N-gonorrhea or C. trichomatis, or both. The syndrome occurs primarily again in young adults under the age of 35 and may be associated with urethritis. Primary symptoms are fever, accompanied by pain in the back of the testicles that develops over the course of several hours. For patients with gonococcal or chlamydial infections, the recommended treatment is ceftriaxone plus doxycycline. For patients who engage in insertive anal sex, the addition of levofloxacin or ofloxacin is recommended to target enteric bacteria. Testicular pain can be managed with analgesics, bed rest, and ice packs. For the non-sexually transmitted epididymitis, generally occurs in older men and in men who have had urinary tract instrumentation. Causative organisms are gram-negative enteric bacilli and Pseudomonas species. Ofloxacin can be used for treatment. Which now brings us to syphilis. Syphilis is caused by the spirochete Trypanomia pallidum. In the US, the incidence of syphilis has risen steadily since the year 2000. In 2012, reported cases of primary and secondary syphilis totaled 15,667. In 2014, reported cases increased to almost 20,000. Approximately two-thirds of cases occurred in men who have had sex with other men. Fortunately, T. pallidum has remained highly responsive to penicillin, and it is the treatment of choice. So, its characteristics. Syphilis develops in three stages, termed primary, secondary, and tertiary. T. pallidum enters the body by penetrating the mucous membranes of the mouth, vagina, or urethra of the penis. After an incubation period of 1 to 4 weeks, a primary lesion called a chancre develops at the site of entry. The chancre is a hard, red, protruding, painless sore. Nearby lymph nodes may become swollen. Within a few weeks, the chancre heals spontaneously, although T. pallidum is still present. In clinical practice, chancres are rarely seen, especially in females. 2 to 6 weeks after the chancre heals, secondary syphilis develops. Symptoms result from the spread of T. pallidum through the bloodstream. Skin lesions and flu-like symptoms are typical. Enlarged lymph nodes and joint pain may also be present. The symptoms of secondary syphilis resolve in 4 to 8 weeks, but may reoccur episodically over the next 3 to 4 years. Tertiary syphilis develops 5 to 40 years after the initial infection. Almost any organ may be involved. Infection of the brain, neurosyphilis, is common and can cause senility, paralysis, and severe psychiatric symptoms. The heart valves and the aorta can also be damaged. Lesions can also occur in the skin, bones, joints, and eyes. The risk for neurosyphilis is increased in individuals with an HIV infection. Infants who are exposed to T. pallidum in utero can be born with syphilis. Early signs of congenital syphilis include sores, rhinitis, and severe tenderness over the bones. So the treatment of choice is penicillin G, and that is the drug of choice for all stages of syphilis. The form and dosage of penicillin G depends on the disease stage. Early syphilis is treated with a single IM dose of benzathine penicillin G. Latent syphilis and tertiary syphilis are also treated with IM benzathine penicillin G. However, instead of receiving a single dose, adults and children receive 3 doses, 1 week apart. Neurosyphilis requires a more aggressive therapy. The recommended treatment is IV penicillin G daily for 10 to 14 days, administered either by a continuous infusion or in separate doses every 4 hours. For congenital syphilis, treatment options are either IV penicillin G or an IM procaine penicillin. Syphilis and pregnancy should be treated with penicillin G, using a dosage that is appropriate to the stage of the disease. How should patients with penicillin allergies therefore be treated? For the non-pregnant patient with early or late syphilis, either doxycycline or tetracycline may be used. For patients with neurosyphilis, ceftriaxone can be effective, but possible cross-reactivity with penicillin is a concern. If the patient is a child or a pregnant woman, the CDC recommends a penicillin allergy desensitization protocol to permit penicillin use, rather than substituting another drug for penicillin. Bringing us to bacterial vaginosis. Bacterial vaginosis is a common vaginal infection in women of childbearing age. The condition results from an alteration in vaginal microflora. Organisms responsible for the syndrome include Gardnerella vaginalis, Mycoplasma hominis, and various anaerobes. The syndrome occurs most commonly in sexually active women, although it may be transmitted in other ways. Bacterial vaginosis is characterized by a malodorous vaginal discharge, elevation of vaginal pH, and generation of a fishy odor when vaginal secretions are mixed with 10% potassium hydroxide. Clue cells are typically found on microscopic examination of vaginal secretions. The recommended therapy for bacterial vaginosis is either oral or vaginal flagyl or vaginal clindamycin cream. Clindamycin cream is available as a short-acting 2% clindamycin cream and a long-acting 2% clindamycin cream. Clindes cream is formulated to adhere to the vaginal mucosa for several days, and therefore can clear bacterial vaginosis with just one application. Approved alternative regimens include tinidazole, oral clindamycin, or clindamycin ovules. Unlike the other drugs approved for bacterial vaginosis, tinidazole should not be prescribed to a pregnant woman. Trichomoniasis. Trichomoniasis, caused by T. vaginalis, is the most common non-viral STD. In the US, in men, infection is usually asymptomatic. However, in women, infection may be asymptomatic or may cause a diffuse, malodorous, yellow-green vaginal discharge, along with burning and itching. The rapid movement of T. vaginalis protozoa are notable on microscopic examination of vaginal secretions. Most infections can be eliminated with a single 2-gram oral dose of either flagyl or tinidazole. Dosing can be repeated in the event of treatment failure. Male partners of the infected woman should always be treated, even if free of symptoms. Although some clinicians remain concerned about giving flagyl during pregnancy, there is no evidence that the drug causes any birth defects in humans. Tinidazole, on the other hand, should not be prescribed for pregnant women. Cancroid. Cancroid is also known as soft cancre and is one of the few STDs for which prevalence has declined both in the US as well as worldwide. It's caused by Haemophilus ducreyi. Transmission is primarily through sexual contact. The infection is characterized by a painful, ragged ulcer at the site of inoculation, usually the external genitalia. Regional lymph nodes may be swollen, multiple secondary lesions may develop, and there are 4 antibiotic recommendation treatments: azithromycin, ceftriaxone, ciprofloxacin, and erythromycin base. Which brings us now to herpes simplex virus infections. Its characteristics. Most genital herpes infections are caused by the herpes simplex virus, type 2. However, an increasing number of anogenital infections are caused by HSV1, the herpes virus that causes cold sores. In the US, the infection has reached epidemic proportions, with more than 50 million people that are affected. Symptoms of primary infection develop 6 to 8 days after contact. Some people with HSV infections are asymptomatic or have relatively mild symptoms. However, for others, there is a common presentation. In females, blisters of vesicles can appear on the perianal skin, labia, vagina, cervix, and foreskin of the clitoris. In males, vesicles develop on the penis and occasionally on the testicles. Painful urination and a watery discharge can occur in both sexes. Also, the patient may experience symptomatic symptoms, which include fever, headache, myalgia, and tender, swollen lymph nodes in the affected region. Within days, the original blisters can evolve into large, painful, ulcer-like sores. Over the next 2 to 3 weeks, all symptoms resolve spontaneously. However, this does not indicate cure. The virus remains present in the latent state and can cause recurrences. Because available drugs can't eliminate the virus, there is no cure. Symptoms may reoccur for life. However, for some patients, subsequent episodes become progressively shorter and less severe, and in rare cases, they may cease entirely. The neonatal infection, therefore, genital herpes in pregnant women, can be transmitted to the infant. Transmission can occur in utero, which is very rare, or during delivery. Infection acquired in utero can result in spontaneous abortion or fetal malformations. Infection acquired during delivery can cause blindness, severe neurologic damage, and even death. To protect the infant during delivery, birth should be accomplished via cesarean delivery if the mother has an active infection. Infants who acquire the infection should be treated with acyclovir. Treatment. Genital herpes can be treated with 3 drugs: acyclovir, famciclovir, and valacyclovir, at dosage regimens recommended again on Table 80.1. These agents cannot eliminate the virus, but they can reduce symptoms and shorten the duration of pain and viral shedding. Patients with recurrent infections may take these drugs every day or just when symptoms appear. Continuous daily administration reduces the frequency and intensity of episodes, whereas episodic treatment reduces symptom intensity after an episode has begun. Reduction of transmission. Again, transmission of HSV can occur when symptoms are absent as well as when symptoms are present. Valacyclovir can decrease transmission of genital herpes by up to 50%. No other drug has been shown to reduce transmission of this STD, or any other STD for that matter. Valacyclovir only reduces transmission, it does not stop it entirely. Accordingly, patients must continue to use condoms. Because viral shedding is increased when the infection is active, it is advisable to abstain from sex during a breakout. Proctitis. Sexually acquired proctitis results primarily from a receptive anal intercourse. Symptoms include anorectal pain, tenesmus, and rectal discharge. Usual causative organisms are N.Gonorrhoeae, C. trichomatis, T. pallidum, and HSV. Empiric treatment is ceftriaxone plus doxycycline. If perianal ulcers are present, treatment for HSV should also be included. Venereal warts. Genital and perianal warts are caused by human papillomavirus, or HPVs. Characteristics of these warts and their treatment are presented in Chapter 85. As discussed in Chapter 53, the HPV vaccine, sold as Gardasil, can help protect against both venereal warts and cervical cancers. Another HPV vaccine, sold as Cervarix, protects against cervical cancers, but again, not against venereal warts. And that concludes our chapter here today. I thank you as always for listening, and I'll see you at the next chapter. Thank you, and goodbye.